Neither the El Paso County Medical Society, its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Good evening. There is much cause for optimism in the world of prostate cancer with new research, both current and also on the horizon. During this next hour, we have experts answering questions about prostate cancer, from early diagnosis and treatment to advanced prostate cancer, and we're going to find out some of the latest screening suggestions that are here. And this is a live show, as you know, so give us a call. The phone number is 881-0013. Think of some questions for you to ask. And then we have with us this evening, we have Lachvin Yo, and also we have Aaron Pine. So they're going to be answering the phones for us and then making sure that we get the questions, and we're going to go ahead and do our best to answer those questions for you. This evening's program is underwritten by the Rio Grande Urology, I was going to say Rio Grande Cancer Foundation, however, the Rio Grande Urology Group. And we also want to thank the Texas Tech Paul L. Foster School of Medicine for providing the medical students for manning our phones. And as always, the El Paso County Medical Society for providing the doctors for you and for underwriting the show each and every month. Good evening, I'm Catherine Berg, and you're watching The El Paso Physician. Thanks again for watching this evening. We are going to be talking about prostate cancer, from early diagnosis and treatment to advanced prostate care. We are streaming live on Facebook. There will also be a way for you to watch this program once again when the show is over on kcostv.org. When you go to watch, then to programs, and then also at the El Paso County Medical Society site, which is epms.com. So this is it's going to be a loaded show. There's going to be a ton of questions, a lot of information, and a lot of times we would like to give you a chance to know that you can come back and watch it again later. With me this evening, we have a veteran to my side. We have Dr. Daniel Vogelweed, and it's in so many ways a good way. I would say he's an old friend, but he's a very lovely, great, and we've got stories that we've had over the years doing the prostate cancer show. But he is our urologist here this evening. We have Dr. Calvin Hahn, who is our radiation oncologist this evening. And then we have Dr. Harut Shahinian, who is our hematologist and oncologist this evening, otherwise known as the medical oncologist. And so these are disciplines within the world of prostate cancer. And even though I gave your titles to the folks at home, urology, I mean, that's loaded. And today we're talking about prostate cancer, but in your world of urology, what do you do all day, every day?
You're not going to like my answer.
I probably won't, but I always do.
The answer I always give is 2P, see me.
2P, see me.
Correct.
I like that.
Basically, we take care of the urinary tract, from the kidneys to the ureters to the bladder, and in men, prostate, and male organs, penis and testicles.
Okay. And so I'm going to ask, one of your first basic questions will be what the function of the prostate is, because I feel like unless you read about it, unless you have a reason to read about it, people don't really know what's going on there, but we'll wait just a couple of minutes for that. Dr. Hahn, you are a radiation oncologist, very different from a radiologist. So I would love for you to explain to the people at home what you do all day, every day.
So radiation oncologists use radiation to treat cancer, not just prostate cancer, but all types of cancer.
And I feel like prostate cancer is that cancer that there's so many different types of radiation that can be used. So it's the exciting one that we get to talk about, at least on the show, when it comes to the world of radiation. And Dr. Shahinian, medical oncology, hematologist, the guy that does the chemo, etc. How do you explain to the people at home what you do all day, every day?
Pretty much generalized oncology, which includes every kind of malignancies, including breast cancers, including prostate cancers that I deal with, including gastrointestinal malignancies, lung malignancies, brain tumors, and all sorts of different malignancies. Those are treated mostly with chemotherapeutic agents, and also we have targeted novel agents nowadays that we're using. And we're doing much better in terms of the outcomes nowadays, in terms of the cancer outcomes. And besides that, I have also hematologic malignancies, which includes leukemic processes, lymphomas, etc.
And just for those at home, because I remember the first time I did this show, I thought, what in the world is hematology? Hematology is the study of the blood. So just how everything works in the world of the blood. So going to our urologist, And I know that we don't have a prostate cancer model here, but if you could describe where the prostate is physiologically and what the prostate does within the body.
Well, if you can imagine a balloon that's inflated and it's stretched out and it has a long, narrow tube that goes that you inflate it through. Well, that tube would probably represent, that balloon would represent the bladder, and the tube is the urethra where the urine comes out from. Well, the prostate actually in men sits around the neck of that tube.
Okay.
And most of the symptomatology that comes from the prostate is because of where it sits. But it's you asked a little bit earlier, it's a sex gland. Without the prostate, men cannot have children. It's as simple as that. It provides nutrients and it provides a transport media for sperm.
Okay. And we're going to talk about it, and just forewarning, because this is a prostate cancer show, we are going to talk about sexual issues this evening, and they're very important issues, and I think often it's easy to not talk about those because they're uncomfortable. So if you have some uncomfortable questions that you've been wanting to talk about when it comes to surgeries with prostate cancer, different types of treatments with prostate cancer, we very much welcome you to call in with those questions because this is a safe place. We don't know who you are. That's what's so great. It's anonymous. It's an anonymous call-in show. So call in with those questions. Again, 881-0013. Dr. Hahn, you are the radiation oncologist. And I feel like we've been doing, first of all, what I'm going to do is I'm going to stop the show for just a second because I'm going to go into the fact that I've been doing this show 21 years. And the very first show I did was with prostate cancer, and I was wearing the hat of the American Cancer Society at the time. And we had Dr. Vogelweed on. We had Dr. Byron Chesbrough on, who is no longer with us. And it's hard to do a prostate cancer show without Dr. Chesbrough. And then we had Dr. Oh my goodness, who were we talking about?
Horowitz,
Dr. Horowitz, and we called them the three prostate bearded doctors.
The cough drops.
Yeah.
The cough drops, yeah.
The cough drops. And they were fantastic. So I just wanted to say, for those of you who have been watching this show for so many years, and the prostate cancer show, we dearly miss Dr. Chesbrough. And again, we've been doing this so long. And going into that transition again, too, I feel like for the last 20 years, when we're talking about something new on the horizon with prostate cancer treatments, it's always been, at least in my head, it seems to have always been in the world of radiation oncology. If you could maybe think back 20 years ago and what the average protocol was for prostate cancer treatment, and you don't have to go into the entire gamut, but to how different it is now 2 decades later.
So about 30 years ago, we don't have the computers and we don't have the software that we have today. So we were using old technique called three-dimensional radiation therapy. That was the best that we could do at that time. And what three-dimensional does is it gives a high dose of radiation to the prostate, but the organs that are right next to it, the bladder and the rectum, gets a fairly high dose. So a lot of patients end up with what we call bowel bladder issues.
Okay.
And now we have a new technique called IMRT, which we now use to deliver precise dose of radiation to the prostate without injuring the bladder and rectum.
And I love, we have a really nice video and several graphics on that, and I'd like to talk about that for a minute. But I remember, and I'm embarrassed to say, maybe a decade ago, maybe 15 years ago, when the radiation seeds were all the rage. Is that still something that is regularly used? And maybe explain to the audience what I'm talking about. And I just think to the seeds of rice of radiation, if you can talk a little bit about that and where we are with that.
So we do have a procedure called brachytherapy, which is putting radioactive seeds into the prostate to kill the cancer. The brachytherapy is still used today, and in El Paso, we're still doing it at Las Palmas Hospital. The issues with brachytherapy is that the side effects are a little bit worse than external beam, especially what we call irritative side effects in the bladder and urethra. So we use brachytherapy more as a salvage. What that means is if the external beam doesn't work completely, if the cancer shows up after external beam, then we can use brachytherapy to salvage those patients, and it's still a very good treatment.
Good treatment still. And we have so many different types of treatment that we work with prostate cancer. I'd like to go to Dr. Shahinian really quick, because in the old days, when I say old days on this show, I'm going to think 20 years ago, prostate cancer-wise. But in the world of chemotherapy now, I feel like for so many years it was intravenous drug. It kind of went everywhere. There really wasn't a lot of targeted chemotherapy, but that is changing quite a bit now for various types of cancer. In the world of prostate cancer, where are we with targeted chemotherapy?
About 20 years ago, we hardly had any of these medications that we're using now, and the outcomes much improved as previously. Survival has improved, the outcomes has improved significantly, although yet we're not up to the maximum. This is a serious illness, but we're able to do much better than what we used to. When I started my practice about 20 years ago, at that point in time, we had only one chemotherapeutic drug, which was the mitoxantrone. And that was the only medication for chemotherapy at that time. There was no other approved medication. And the mitoxantrone was used only for palliation, pain management. There was no survival benefit. Then comes Taxotere, which is another medication that we're using. And we have the cabazitaxel now, which is another medication. On top and above, we have targeted therapy, which targets different kind of portions of the body, including androgen receptor blockades, and also we have androgen synthesis blockades.
Okay.
So both ways, those are showing much better. Nowadays, the chemotherapy we used to keep it at the tail end because of the potential side effects. Now we're bringing in up front. Now we have gained almost 1 year of survival benefit. Instead of living about 5 years, now with that short period of chemotherapy, they're living 6 years.
Okay.
So that's a
So
price
we've
to
added
pay.
an
It's
extra year on that.
additional benefit.
Okay.
Then up front nowadays, it's coming also the abiraterone, which is another androgen blockade, which together with the androgen blockade in general, using that together, also adding quite significant amount of life, almost a year, almost comparable to the Taxotere.
Okay. And this is quality of life too, which I think is something that's important to say, because I know we talk often about life, but quality of life. What I'd like to do is bring the show back in for a little bit, because there are, and Dr. Vogelweed as the urologist, let's talk about screening. And after that, we'll talk about different types of diagnosis, staging, and all that good stuff. But for, let's say, the American Cancer Society, let's say for the National Cancer Institute, are there still ideas of, well, we suggest this and the others suggest that? Where are we in the world of screening with prostate cancer?
The United States Commission, it's a whole bunch, about 6 or 7 different letters, and I always forget what they are, but in 2012, they said you shouldn't screen anybody for prostate cancer.
I remember when that came out.
And then we found that we saw a shift in the pendulum from diagnosing it early, and there's a reason for all this, and I don't think we have time to go into all of it, but we were diagnosing it early, and then now, 4 or 5 years later, we're finding more advanced disease because we didn't diagnose it on time. There was just a publication from the American Urological Association came out a day or two ago that said screening for PSA actually saves lives, and it not only saves lives from prostate cancer, it also, just because you go see the doctor and you get screened, it saves other lives at the same time. And so from that point of view, it's good. Now, when we screen, the way of screening, you do 2 things. One is a digital rectal exam, which nobody likes. And I can honestly say that in 38 years, I've never seen anybody that likes the exam. Not one.
Can I stop for just a minute? Because as a girl, we have to go in to the OBGYN, and we also have to be prodded every single day.
Correct.
And I cannot say that I've known any woman that enjoys it either.
Of course.
So it's 100% of the population. So men, I know it's not fun, but the girls got to do it too. So just do it. I'll stop there. Go ahead.
Anyway, nowadays, David Crawford from the University of Colorado put out a chart in 2015 in which he said that everybody should be screened just like they're screened for cholesterol, triglycerides, and any other routine blood tests. If their PSA is less than 1.5, it used to be that anybody has a PSA less than 4 is okay.
Okay.
And that number was totally arbitrary.
And are we talking PSA on its own, the blood test standing on its own without the DRE, without the digital rectal exam?
Yeah.
Okay.
Yes.
Okay.
If the PSA was less than 4, it was okay. Nowadays, if it's above 1.5, the suggestion is that you refer that patient to a urologist.
Really?
Okay.
Okay.
Now, the urologist is not going to go and biopsy that prostate and treat him for cancer.
Right.
But nowadays, we also have several exams or tests like Select MDX, PCA3, 4K score. I won't get into those, but those are tests that you can do on the patient that can assess the risk of prostate cancer. If it turns out that they're high risk, then you can proceed to do a biopsy. And you can catch cancers in somebody with a PSA of 1.
Wow.
Okay, depending on the circumstances.
Right.
So it has changed a lot, and we have a lot more means to be able to diagnose it early. Now, the second thing about that is even if you diagnose it early, it doesn't mean that you're going to treat it.
Right.
A lot of people have low-stage cancer, and they may live the rest of their lives with no treatment at all.
And we were talking about surveillance on that. So I know we've got several treatment options. One of which it used to be called watchful waiting. Is that correct? And now it's
active surveillance.
Active surveillance.
Yes.
And that could very well be something we're talking about. And I don't want to disregard the two of you for a second, but since we've got urologists speaking, let's talk about diagnosis. So we've got a PSA, let's say it's 6, you go in, their digital rectal exam, you definitely feel something, we're going in, there's a biopsy, there is a cancer. How is the diagnosis done and the staging of diagnosis? And if you want, you're welcome to just take a case study in your mind and kind of explain to the audience, because I know that could be, there's so many. And I respect that. But maybe we can take one that's perhaps the most common or one that's easy to kind of take through the process of, do we do radiation treatment? Do we do surgical treatment? Do we do watchful waiting? Do we do hormone therapy, etc.? So I'll just let you take that however you'd like.
Well, to start out with, just because you have a high PSA does not mean you're going to have an abnormal digital rectal exam. More often than not, you do not. It's a normal exam, or it's an enlarged prostate. What's going to dictate whether you're going to do a biopsy or not is if you have a legitimate suspicion. And usually, in my own personal practice, if I have a PSA that's above 4, unless it's a sickly patient, I'm more likely to go ahead and proceed with biopsies. Obviously, the higher the PSA gets, the more likely I am to biopsy that prostate. You biopsy the prostate and it comes back negative. Well, cool. You still have a high PSA, you still have to follow them because you may have an occult cancer. And there's additional tests that you can do for that. If you do have a cancer, usually the standard is to do 12 biopsies.
Okay.
If you do 12 biopsies, then it depends how many positive biopsies you get. If you get 1 out of 12, 2 out of 12, 12 out of 12.
And if you can explain really quick, because I can see how this might sound to an audience member, 12 biopsies. You're doing this all at the same time.
Correct.
Correct? So maybe explain that, because when they think 12, do I go in 12 times? It's
No.
all being done at the same time.
It's all being done at the same time. It takes about 10 minutes.
Okay.
It is uncomfortable. We usually do it with a little bit of local anesthetic. We do what we call a block, and it takes less than 10 minutes to do.
Nice. Okay.
But if it comes back and it's a low-grade tumor and there's not a lot of cancer, you can watch it. That's active surveillance. It depends on the grade of the tumor. Usually we grade them from 6 to 10, where 6 is the least bad and 10 is the worst. Generally speaking, 8, 9, and 10 are bad cancers.
Okay.
A 7 is sort of somewhere in between, and 6 is usually the one, unless you have a lot of positive biopsies, is the one that you can watch.
Okay. And these are grades, and then there are levels. There's level 1 and 2 that's kind of grouped together, then level 3, then level 4, and then there's Gleason. And I don't want to spend too much time on it, but because you hear it and you read it, I'd like to spend a tiny bit of time on it just so that as it's coming around and people are reading about this, they sort of know what we're talking about.
The Gleason score just basically, the Gleason score is 6, 7, 8, 9,
Okay, so
10.
that's the score
That's
that you were
the
talking
Gleason
about. That's
score.
called the
Yes,
Gleason score.
yes.
Okay, gotcha.
Okay, and you also decide what you're going to do depending on the Gleason score, depending on how many positive biopsies you have. Now, if you want to rule out whether that cancer has spread, there are 2 tests we do, a bone scan and a CT scan,
Okay.
or a CAT scan. The bone scan, most prostate cancers initially metastasize to the bone, and so that's to determine whether there's any spread to the bone. A CAT scan is to see if there's any spread outside of the immediate prostate or to the lymph nodes that are right around the prostate.
Okay.
It can spread further, of course.
Okay.
But those are the 2 initial tests that you do if you are contemplating treating this patient.
Okay.
If either one of those tests is positive, it's considered advanced disease.
Okay, and that's exactly, and I know that we have some very specific things that we're going to talk about advanced disease. So I think, would it be fair to say that any time a metastasis occurs from any time there is cancer outside of the organ that is the origin, that is advanced disease at that point?
Correct.
Okay, so I'd like to stop there for a second because I know we're going to treat that and talk about that very differently. What I would like to do, because we have a beautiful video on this, I'd like to talk a little bit the IMRT, which is the intensity modulated radiation therapy. And Dr. Hahn, I would love for you to take it away. I apologize for my voice. I'm going to clear my voice. It's going to sound really gross. Excuse me. Excuse me for that. But what I'd like to do is, for Mario and the guys in the back, if we can set up that video so we can walk through it. And what it is, for the people at home, it's about a 4-minute video. And Dr. Hahn's going to kind of walk us through what's happening in the video. It's going to go fast. But what we may end up doing is, as you're walking us through it, we may end up running it again and walking through it again. Because before we start the video, I want you to just explain a little bit about what we're going to see prior to us seeing it. Dr. Hahn?
So, excuse me, IMRT stands for intensity modulated radiation therapy, which is the most common technique that we use to treat prostate cancer today. And IMRT allows us to deliver a very high dose of radiation to the prostate without injuring the adjacent organ like bladder and rectum.
Mm-hmm. And that's so important too, because again, years ago it was very different. It wasn't targeted. So if we could run that video whenever, and you'll see it on this screen, Dr. Hahn, when they start the video. Here it goes.
So this is a linear accelerator, and this linear accelerator allows us to safely and accurately deliver a precise dose of radiation to the prostate. So inside the machine, you have a either magnetron or klystron, which pumps high-frequency microwave into the waveguide. And you have the electron beam that's injected into the microwave waveguide. And the electron beams are accelerated using the high-frequency microwave. And as the electrons comes down to the microwave, at the end of the tube, the electron approaches almost the speed of light. And after it comes out of the waveguide, it goes into the flight tube. And inside the flight tube, we have a magnet that bends the electron beam. So you can see the tiny little beam that's coming out, and that hits the tungsten target. And when it hits the tungsten target, it makes a cone-shaped beam X-ray.
Okay. It does, I mean, it's very targeted. And is that the end that we're looking at there?
No.
Or? No.
Well, when the beam comes out, the machine has to flatten the beams to make sure that the energy of the beam is the same. And this is a part that really unique about IMRT, is that there are little tiny tungsten leaflet, about 3 millimeter to 5 millimeter, at the end of the beam. that goes back and forth, and that shapes the radiation beam. And all of this is completely computerized, and you can actually see the beam in the head of the gantry that are moving back and forth. So the computer is telling these beams how fast to move, where to move, and how much to move.
Okay.
And this has to be done in real time because the X-ray beam is on while these beams are moving. So this is.
And maybe I missed it. So is this all computer generated from measurements taken prior to?
Right. So
Okay.
this is generated by the computer. So before we treat, we scan the patient on CAT scan.
Okay.
So once we get the images from the CAT scan, then we know exactly what the shape of the prostate looks like. So here you have a cartoon of patients getting the radiation, and then you can see these leaves moving back and forth.
Okay.
Precisely the shapes that the computer is telling
That is amazing to me.
the
Yeah.
machine to do.
So this is within the prostate, and this is targeting the tumor itself. So it's not necessarily targeting the entire prostate.
Actually, it's targeting the entire prostate because we
Okay.
have to treat the entire prostate.
Okay, that makes sense.
And here you can see the beams coming in and out, and you have 5 beams from 5 different angles. And the center part, you see the prostate, which is the PTV. And this is the old 3D technique. And here you can see the doses to the rectum and bladder. On the right is 3D RT, and you can see the red area, which are the high dose in the rectum and the bladder.
Okay. That is impressive. Again, going back to the time when we had the seed. So when we were on a show, it was a breast cancer show maybe a year ago now, and there was Dr. Gupta was on the show, and she was also talking about something that was such a very targeted radiation beam that literally the woman would suck her breath in as the machine was targeting a very specific part of the breast, hit only that specific where the tumor was. And it was, again, amazing to me because it is so targeted now.
Right.
And it would be nice to know where we would be sitting 30 years from now, or actually just 10 years from now, which is 30 years from our beginning. But what we would be doing 10 years from now when there's all this targeted stuff. So Dr. Hahn, since you're on the hot seat right now, I know that you go to seminars and trainings. What's coming up? I mean, this is fantastic, but I know there's new stuff on the horizon too.
Right.
And Dr. Shahini, we're going to ask you the exact same question in a minute too.
So one of the treatments that a lot of the big institutions are doing is the proton beam radiation therapy. Proton beam radiation therapy uses a particle instead of the high energy X-ray. And because of the physical characteristic called Bragg's peak of the proton, you can deliver a lot of radiation to the dose without the radiation coming out the back of the beam. Mm-hmm. The only problem with the proton radiation treatment is that these machines cost anywhere from $50 to $75 million. So
$50 to $75 million.
So a lot of the community hospital or moderate-sized hospital cannot afford to buy it. So
do we have one in El Paso?
Unfortunately, we don't have a
Okay.
proton beam. The closest is MD Anderson in Houston.
So if anybody wins the lottery tonight and likes you, I'm going to have them telephone you and see if we can get something done about that. But the nice thing too is, and I mean this in all seriousness, we do have. I joked earlier when I say Rio Grande, I always think Cancer Society, but they are there are some travel help that the Rio Grande Cancer Society can give to people who are not able to get treatment here in town, although the first sign of treatment and line of treatment you should get is always in your own hometown. There's everything. We have so much here, and you've got your support pool here. Dr. Shahinian, let's talk about prostate cancer and chemotherapy. It doesn't seem that for so many years that always went along. I feel like for so many years it was, let's do surgery, let's do radiation, and sometimes let's do chemotherapy. Again, that changes every single year, every couple of years. In the world of chemotherapy and prostate cancer, where are we sitting now? Because again, there is very specific and targeted treatment now, which is lovely.
That's absolutely correct. So nowadays, the treatments are changing. It's a dynamic thing. It's not a static thing, and always we have new, novel ways of doing things. Most of the recent updates that came in with the prostate cancer, it incorporated regular androgen deprivation therapy together with chemotherapy, which is the Taxotere. So this was studied, and it had shown significant improvement as chemotherapy. Now, chemotherapy is not a terrible type of situation in terms of the side effects. The side effects are very manageable. So the Taxotere has been studied in high-volume prostate cancer, which is hormone naive. It's not the hormone-resistant type.
Okay.
And in the hormone-resistant type also, we have a similar type of approaches that we can do. It does by quite significant amount of time in terms of the life expectancy. So as we discussed earlier, there's about 1 year survival advantage, about 5 years versus 6 years for the price of 6 treatments, which is every 3 weeks with the chemotherapy.
For the price of. I like the way you talk. It makes sense, though. Yeah.
So it's not as expensive to
Yeah.
the quality of life, which is an important factor in terms of the treatment. Quality of life does not get affected much. It's tolerable, it's doable.
Right.
The second option with the targeted therapy is the abiraterone, which is another medication that we use with the androgen deprivation therapy. It's 2 medications together. And the data, again, this is with high volume hormone-naive patients that is being used, and the outcome seems to be pretty comparable. The difference in that is that the tablets, you'll have to take it every day.
Okay.
Versus the chemotherapy, which you take one time every 3 weeks. So the options are that it's valid options. Both options are available.
And a pill a day is not a bad thing. And it's interesting because we were just...
4 pills.
Oh, it's 4 pills.
Yeah,
well,
and,
still.
and there's an additional argument there because it's cheaper to give them the chemotherapy than it is to give them the pills.
Is it really?
Because the
I would have thought
chemotherapy-
just the opposite.
No, well, the chemotherapy is a limited treatment. Correct me
Okay.
if I'm
That's
wrong.
correct,
I
yes.
see.
And whereas the pills you take until they no longer work, and the pills are very, very, very expensive.
Goodness. Okay.
But most patients don't want the chemotherapy; they'd rather have, and the outcomes are pretty much the same as he said.
Yeah, yeah. And again, that's one of those, this of all the cancers is a cancer that you really need to study, talk to your doctor, talk to your family, figure out where lifestyle fits in all of this as well. So we've already touched base on some of the questions here from the audience, which was the androgen and prostate types cancer. So, okay, so we've got that here. We want to touch about diets really quick because the question here from the audience and just what they read in general. Prostate cancer and diets, I don't know much about that. Is there a lot to study in the world of...
There is suggestions, but
yes.
there is no lots of studies. But the Western diet, that is our diet, the way that we go with, it has been suggested. And it has been associated with lots of cancers too, including the breast, colon. It's suggested that Western diet can cause this kind of situations. And
when you say Western diet, throw some specifics out there, like what types of stuff
higher
are we throwing
fat
in there?
content,
Okay.
probably more quantity of the food, less vegetables probably, less fiber intake. Those are the kinds of food probably which we are not very compliant with our diet. It's completely different than the Eastern diet where they have less meat products probably. It may be, but again, these are all conjectures.
No, it's interesting. We hear it all the time.
Yeah, there's no firm data about it, and their dietary modifications has been advised. It has been studied in colon cancer, in terms of breast cancer. People get diagnosed, get treated. Those cohorts that they diet, they lose weight, the outcome, again, cancers can come back, but the outcomes becomes that it is less frequent in terms of the malignancies as opposed to people who don't diet.
Right. And I don't know why I remember this study, and Dr. Vogelweed, you can make fun of me, but I remember this group of little old men in Italy that had a certain way of cooking their tomato sauce, and it's probably 15 years ago now, but it was like no one in that area ever got prostate cancer, and we were like, okay, let's study that tomato sauce. It's a joke now because I don't know if anything went anywhere with that, but that's the first time I heard about diet and prostate cancer. But
they were saying that tomatoes, if you eat a lot of tomatoes, but those are isolated instances, and you really can't compare them. They haven't proven that is of any value.
Right.
treatments that we have nowadays compared to what we had 20 years ago are so incredibly better. And research is being done every single day.
Right.
And I mean, it's hard for us to keep up. I mean, I don't know how they do it because they have to keep up with, what, 127 cancers or something of this sort?
Jeez.
Whereas,
And every day we get a new approvals of new medications. It's ongoing thing.
Yes.
It's
Yeah.
ongoing thing.
Exciting,
But it's
though,
a good
I'd
thing.
imagine,
It's
yeah.
a good thing.
Yeah.
And the cancer survival has improved dramatically.
Significantly, exactly. I'd like to, we have a video, and it's your video, Dr. Vogelweed, so it's going to be the same guy. Oh, it's not. We're not going to use. Okay. So what I'd like to do, we had a video, but the audio's not working. Instead of driving you guys crazy with the audio not working right, I would like to kind of move over to pretend you're that guy on TV making the video about advanced prostate cancer. So if you could, we talked about a lot of the base, a lot of the treatments from here on out, but let's talk about advanced prostate cancer now. Let's talk about surgeries. Let's talk about side effects, even though they're uncomfortable to talk about. But I think that's important to people at home as well because we don't get to hear a lot about that.
advanced prostate cancer basically is the cat's out of the bag.
Right.
Okay. Now, you could be somebody that presents initially with advanced prostate cancer. When it's originally diagnosed, it's already spread. Advanced prostate cancer is also somebody who has been treated for prostate cancer for a cure, and it didn't work, be it by radiation therapy or be it by surgery. Okay, and then once you get into advanced prostate cancer, we have what we call M0 disease, which is basically you have chemical progression, your PSA starts rising, but there's no evidence, no radiographic evidence of advanced, or you have metastatic advanced prostate cancer, where you actually have metastatic disease. Now, you may have somebody presented initially with advanced prostate cancer, and you treat that, but there's still advanced prostate cancer. Whereas if you're treating it initially for a cure, you may cure them forever, but then you may not.
Right, right.
But anything that is beyond cure is advanced prostate cancer.
And so this is anything beyond the cancer leaving the prostate gland itself. So you were
Correct.
talking about spreading earlier, and usually the easiest and or most common place to spread is the bones. Is that correct? And then from there, where?
Well, bones and lymph nodes. That's
And
the
lymph
two
nodes.
that we check.
Okay.
It can go to the brain, it can go to the liver, it can go to the lungs. More often than not, it goes to the bone and the lymph nodes.
Okay. And so from there, treatment. Surgery, chemo first, make
Once
things
it's-
shrink, surgery. I mean,
Okay.
and I know it's different for everybody.
Well, once it spreads,
Yeah.
surgery is out of the question.
Okay.
Okay, unless you have a broken bone because you have metastases of the bone and you have to fix the bone. That's surgery. Or and radiation too. If you have metastases to the bone, you can treat that with radiation therapy.
Okay.
But it's no longer within, for a cure.
Okay.
The main treatments are medical, and it's either we have immunotherapy, we have hormone therapy. Most prostate cancers are sensitive to hormone treatment.
Right. Okay.
The problem is that prostate cancer cells are very smart. They're extremely smart, and they can figure out just about anything you can throw at them, and that's why we can't cure it. But we started out, and the only treatment we had was hormone deprivation.
Okay.
And that was, that was either removing the testicles or that was treating them with a shot that blocks male hormone. Well, we found that at the cell level, they have developed a resistance to that. And then you start getting into the medications that fight that resistance. One of them is enzalutamide that he mentioned, the other one's abiraterone. Abiraterone blocks the synthesis of the male hormone, whereas enzalutamide blocks the effect that it has at the cell level.
Okay.
Okay,
Okay.
and it permits, to fight the cancer at the cellular level, and it blocks it at 3 different levels. The effect is pretty much the same. They're just 2 different forms of treatment.
Okay.
We have immunotherapy, where we can actually have the patient come or go to the blood bank, and then they do plasmapheresis. They take out his white blood cells. They ship them out. They teach those blood cells to fight the cancer. They bring them back 3 days later.
That is fascinating. That's relatively new, correct?
That is relatively new, yes.
I'm curious about that. So you take the white blood cells out of your system.
Yes.
You ship them off to get them retrained.
Correct.
How does that work?
I wish I knew.
I
I'd be rich.
Yeah.
No, I mean, basically they expose the cells to an antigen, which is basically I forget the name of it. It's, but I'll think of it in a minute. But anyway, they expose it to an antigen, and then they incubate it. And then so in other words, they teach these cells how to fight this specific antigen.
Interesting.
And then they bring it back to the patient and infuse it in the patient 3 days later. It's critical to be done in 3 days. It can't be 4, it can't be 2. And then it's infused back into the patient, and the infusion takes maybe an hour or so.
And you're fighting the cancer yourself with
That
your
is
own
correct.
body, with your own white blood cells that have been retrained.
That is correct.
When, and you may not have the answer to this, when that...
Acid phosphatase is the
Yeah, because
antigen
no
they
one
use.
has a clue what that says.
Okay.
And I love that you're taking stuff out and writing notes. So let's say you've done this. Are we done? Do we wait for your body to have attacked these cancer cells now? Is it something that you can do again if it's not working?
No, you can't.
It's done once.
It's done once,
Okay.
and there's no way to measure the outcome. It will not affect your PSA. The only way that we know that it works is because they did a double-blind study where they gave some people blood cells that had been treated and other people blood cells that had not been treated. And they found out that their long-term survival is better. Okay. So it's just one step. That's not the end of the treatment. It's one step in a series of steps that we take to treat that prostate cancer.
Okay.
The other treatment goes back into his ballpark, which is Zofigo, which is radium-223, and he can explain that to you.
Okay, Dr. Hahn, you're on. Oh, I like that. Dr. Hahn, you're on.
So there's a treatment called Zofigo, which is also relatively new, and the Zofigo is a antibody with radium-223 that's attached to the antibody. So this antibody
Naturally attached.
chemically attached.
Chemically attached.
Right.
Okay. All right.
So this antibody looks for prostate cancer, especially in the bones.
Okay.
So when you give the Zofigo, the molecule will find the prostate cancer in the bone, and then in the back of the antibody is the radium-223, which is a radioactive bomb, which blasts these cells. And it's been shown that the patients who were treated with Zofigo gets better pain relief, and also there's improvement in overall survival for those patients.
So pardon my ignorance on this. Is this beam treated?
No,
is this okay? So this how is it distributed?
So it's given intravenously, and we just inject the Zofigo into the vein.
And so it goes through, it's system-wide.
So it circulates around the entire body.
Okay, and it's like a bomb. I love the way you describe this. Okay, so that's yet another form of treatment. I've got, literally a laundry list of things here. We are coming down to our 12-minute mark. But Dr. Shahinian, before we go to what we haven't talked about yet, we've talked about a couple of things already that are so targeted. And it's different with everybody, I get it, but do you have a favorite or a go-to treatment in the world of prostate cancer that you would like to speak about? Dr. Vogelweid's laughing like there's no such thing.
I don't think there is kind of a sequence of events that you have to go and sequence it. That has not been studied, and it's randomly studied from one treatment to another treatment, and we don't have a sequence of events. This is where you start. There's no algorithmic type of treatment events. The main thing that we need to distinguish is the prostate cancer situation. Is this hormone sensitive or castrate resistant, meaning it doesn't respond to the cancer?
Good point.
Then
Okay.
it kind of gives you an idea.
Okay.
Now chemotherapy can come in both ways. it just started. Before it was just with the castrate
And
resistant.
how long does it take for you to know if there's going to be a response? Is that something that's pretty immediate?
It's fairly, with the chemotherapy options, we can know with the PSA, with the patient's symptoms, with the quality of life issues, and then also we have the imaging studies. When you do the imaging studies, you do a bone scan. And here you have in the bone scan, the bones are lighting up with radioactive compounds that you can image. So you see bony lesions. The bony lesions are not measurable disease, so it's difficult, it's tricky in terms of the evaluation. I'll come to that in a moment. But yet you have solid tumors, lymph nodes, that you can measure it. You may have liver metastasis, as Dr. Vogelwood was saying, or you may have brain metastasis or lung metastasis. Those are easier to measure because that way you can go with a CT scanner, you can see what was the dimension, you can remeasure it, you know what it is. The bone is a little bit tricky. Why is it tricky? Because you have two types of activities in the bones. One of the activities in the bones when the tumor cell kill is achieved, so the bones have to regenerate. Once they regenerate, it's called osteoblastic activity. That osteoblastic activity does light up. So if you do it within short period of time, a bone scan within 3 months, it will show that it's getting worse instead of getting better. So it will not be able to kind of give you an idea what's going on. However, it's easier to measure the tumor dimensions, wherever that was from the beginning, from the start. And that way you can know within 3 months or so. I can leave the bone scan part at a later time. And then also I can measure the PSA. In certain situations, the PSA is tricky. You cannot kind of get a good feel of the PSA. But frequently, if you measure the PSA, it will give you an idea of which way you're heading, which way it's directing, and it's going to give you quicker idea. If I start a patient on the treatment and the PSA was, let's assume 1,000, when the normal is should be, ideally speaking, in prostate cancer patient, less than 1. But let's assume it was 1,000. You do the chemotherapy, you see it drop down to 800, you see that progression. On the other hand, you come across situations that radiographically, you see especially in the taxane type of, or the taxotere chemotherapy, you see some drift downwards and then it kind of goes up, but you cannot kind of rely on that test alone because that's going to be tricking you because sometimes it might go up, yet the patient's symptoms, quality of life, the pain that was experiencing is much better. Now we have measurable disease. We see kind of discrepancy between the PSA versus the tumor burden that we saw before and now. So therefore, you continue with the treatment as long as the patient is doing well. The side effect profile is reasonable. You continue with the treatment.
Nice. And it's beautifully explained, too, because I feel like prostate cancer, it's goodness, the treatment changes, so and should. That, for example, with breast cancer, it's like, you know what, I've got 6 months of this and 6 months of that, and it's almost like it's predetermined. But here you can actually take measure and markers along the way to see, okay, what direction are we going to take now? And that's so nice, too, because you're able to stay on it, and there's a team of doctors putting all this together. We're at the 9-minute mark, so what I want to do is stop questions from me and from the audience and talk about Dr. Vogelweed. We'll start with you because there's so many things that we haven't talked about. What is it that we should talk about before the show ends? Because you know how fast this goes, so go for it, whatever you want to say.
Well, I think still to this day the most important thing is screening.
I agree.
Yes. You need, men don't realize that you should start screening probably at the age of 50. They still say, well, you don't really have to be screened. It's between you and your patient. You can decide what you want to do. Well, anything you do with a patient is between you and your patient. I usually recommend that white males should be screened from the age of 50 on. If they have a PSA that's less than 1.5, they probably don't need to repeat it for 4 or 5 years.
I'm going to stop just for a second because you said something beautiful earlier that I loved. You said you're going to go get screened for prostate cancer, but within that, chances are your doctor is going to screen you for a bunch of other things too. So talk a little bit about that. So yeah, you're the urologist. We're talking about prostate cancer, but there's other stuff in the blood too that you can see with blood tests. Maybe talk a little bit about that, of why it's good just to get a screening, not just for prostate
it's
cancer.
not just the, I don't do all the other blood testing, and if you were to ask me to look at it, well, I could probably give you an idea because I went to medical school.
Right, yeah.
But I don't think it's so much, it could be blood tests, it could be the urine. You may find a urinary tract infection. As a matter of fact, you can have a high PSA if you have a urinary tract infection and not have cancer. You examine your patient. You may find a lump in his testicle. You may find something in his tummy. You may see something that's suspicious for a melanoma. You're looking at a patient
as a whole.
As a whole. I mean, we don't do the same exams that an internist does, but there's always a chance that you may. I've had people come in with back pain thinking that it's their kidney, and it really is just a back problem. I've had people coming in because they're peeing real often and they say, oh my God, something's wrong with my prostate, and they have diabetes.
Right.
Okay?
Yeah.
So, there's always a chance of picking something else up. I mean, I would never go see my urologist as an internist because we're not qualified.
Right.
But certainly if you do see your urologist and he does examine you and looks over some of your tests, he may pick something up that you otherwise wouldn't.
And I agree with that. And I know in the female world, often the one test that women go to get their pap smear and get the breast exam. Even though that's not the internist that they're usually going to see, there's stuff that gets picked up there too. At least it's one touch with the doctor a year. So
exactly.
that's kind of the point that I'm talking about, because there's something that you can kind of catch or see. Dr. Hahn, you're looking at me with such a deadpan face, thinking, what am I going to say? So this is your time to shine. Anything that you want to talk about?
So what I want to bring up is for a small group of patients that has what we call nodal metastases only. So that means the cancer has left the prostate and went to the lymph nodes. And then after we stage the patient to see if there's any place else, if those patients don't have what we call the bone met or visceral metastasis, which is the metastases to the lung, liver, and the organs, a small group of those nodal metastases patient can still be cured with radiation alone, or there's some data that shows that radiation and the new oral chemotherapy called Erleada, which is apalutamide.
So this is metastasis from the prostate, but only to the lymph nodes.
Exactly.
And nowhere else.
Right.
But that's still a big deal.
Right.
And you use the word cure.
Yes.
Which is something we weren't allowed to do years ago.
So for prostate cancer with a nodal metastasis, with radiation, about 1 out of 4 can go on to live for 10, 15 years.
Very nice. And again, quality of life, and that's something, when we're done with this, I want to talk about quality of life, and Dr. Vogelweed, that's probably going to be all on you. But Dr. Shahinian, is there anything that we have not talked about that you'd like to talk about this evening, or anything you want to just speak a little bit more about?
I want to refresh about the screening that Dr. Vogelweed brought. I think I'm pro for screening, although I do understand the U.S. Task Force agenda, how they have to do it, because there's false positive results.
Yeah.
And the false positives are not an easy thing to deal with. Some people get really anxious about the false positives. And then yet, not only that, you have to do extensive testing. You do biopsy. I've seen patients, PSA of 20, you do biopsies back and forth, turns out to be negative. Select MD comes to play a role, for example, that Dr. Vogelweed touch base. Or we have newer enzyme-based studies that are coming up in the blood that may be helpful in those regards. But regardless, screening is important. And I think we pick up situations that we can reduce. Where I'm coming from is also the most recent statistical analysis shows that we are increasing the prostate cancer mortality. Before, that was plateauing, even going down. The most recent studies is their suggestion over the last few years that the mortality, meaning we're catching people at the later stages.
So when there was that time when there was a suggestion not to screen,
that's right.
That's
now
starting to
we're
catch up.
catching at the later stages.
I see.
It's more disease we cannot cure, therefore more deaths associated with it.
So this goes to early detection is the key.
Early detection, I think is the key. But again, I don't understand the U.S. Task Force opinion about it, because we're trying to eliminate certain situations. And this is screening. And screening needs to be cost effective, and we need to reduce the mortality and the morbidity associated with the disease process. But those data were being mixed. Nowadays, it's coming back.
Right.
The American Cancer Society has approved. No, I mean, they are not the ones that they will decide, but they are okay with that. But some of the other organizations, they are kind of going back and forth. So you see there's different dimensions, different thought processes of different organizations.
And here's the bomb that I feel like I'm going to drop right now is insurance. And so when you're looking at all, and I think that was an issue several years back, is when does insurance then pick up a screening? Is that at the age of 50? Is it if you've had other, and this is a group of doctors. I know this is not your area of expertise or touch
Sure
it,
it
but,
is.
okay, then talk about that, because again, that makes me mad.
Well, I mean, it's our area of expertise
Yeah.
because we get denials all the time.
Right.
But generally speaking, in prostate cancer, if I order a PSA, if I order 3 of them a year, they don't deny it. If I do have a patient that I'm screening just on an annual basis, they will only do 1 a year.
Okay.
I haven't had too much of a problem with that. But I do have problems when I have patients with advanced prostate cancer and I want to do an additional test for whatever reason, and a legitimate reason. I also have, and the insurance company will deny it. One of the most important things in treatment of advanced prostate cancer, as soon as you put them on hormone deprivation, they start losing bone mass. They lose about 4.6% of their mineral in the bones per year. And so you talk to an insurance company and they say, well, he doesn't have osteoporosis. Well, the indication is not osteoporosis.
Right.
The indication is prevention of skeletal-related events. It's prevention. But they don't care.
Right.
It costs them money.
It's frustrating.
It really is.
I can't imagine being in your seats and dealing that. And it's not just here. It's with every doctor, and I'll leave that aside. So we only have a couple of minutes. So I want to say Dr. Vogelweed, Dr. Hahn, Dr. Shahinian, thank you so much for being here this evening. I do want to give a shout out to medical students here in the El Paso area. There is going to be oh look, even got a high five, hey. There's going to be a run which is going to be held on October 28th, and it's going to be at 8 a.m., and it's going to be up by Scenic Drive. And if you can sign up, they would very much appreciate it. It's for the student-run clinic that's on Spark Street, that's right outside of Horizon. And it's free to people that go, and that's so important. And the funds that are being raised is to help buy things for the clinic, different medications, just different equipment there. Again, students are learning, and the public is getting a real nice care from there. There are real doctors there that are helping out as well. But again, that's going to be October the 28th. You can go to tinyurl.com/sprint4sparks15. Thank you so much for watching. I'm Catherine Berg. Good night.